First, I would like to thank the organization committee for inviting us to this valuable conference. I would like to mention about tips and tricks for the endoscopic treatment of benign prostatic hyperplasia. I'll start with definitions and terminology of BPH. As you may all know, BPH is defined as a disease process characterized by stromal and epithelial cell hyperplasia beginning in the periurethral zone of prostate. As you may all know, the chief complaint is characterized by LUTs of urinary frequency, urgency, nocturia, decreased and intermittent force of stream, and sensation of incomplete emptying of bladder. Last suggestive of BPH, now used in place of the older term of prostatism. And you are seeing the zones and main parts of the prostate, the central zone, transitional zone, peripheral zone, and external urethral sphincter. Defining the demographics, the prevalence of histopathologic BPH is age dependent, and it is usually seen after the age of 40. By 60 years of age, the prevalence is getting higher, approximately 50%, and by the age of 85, it becomes as 90%. The prevalence of bothersome symptoms also increase with the age, and symptoms worsen in 55% of patients, remain stable in approximately 30% of patients, and improve in 15% of the patients. Clinical progression includes worsening of bladder, decrease in quality of life, need for surgery, and urinary retention. And the main point in this section is decrease of quality of life, decreasing quality of life. Men with prostate volume mainly higher than 40 milliliters are three times as likely to have elevated symptoms, but it differs in populations, and it differs from one population to another. The growth and the development of the prostatic hyperplasia is under the influence of male hormonal balance and testosterone and dihydrotestosterone levels. The enzyme responsible for conversion of testosterone to dihydrotestosterone is 5-alpha reductase, and we are using inhibitors in our daily practice, as you may all know. The development of histologic BPH requires aging and androgens. When talking about the pathophysiology of benign prostatic hyperplasia, BPH requires DHT stimulation of androgen receptors, and this results with transcription and translation of growth factors such as epidermal growth factor. This in turn promotes the stromal and epithelial hyperplasia characteristic of BPH, and you are seeing the balance of the hormonal types. And when talking about increased production of the DHT cell profile, the balance is going to the cell proliferation one, and it results with the BPH. A medical history is the main point of diagnosing BPH and should be taken into consideration. And the other one is other important point is physical examination, including digital rectal examination, and this is one of the main points of diagnosing BPH. And also when diagnosing the prostate cancer, also the digital rectal examination is one of the most important points with the PSA levels. Urinalysis is also an important point and should be performed with dipstick testing or microscopic examination of the sediment. Well, this is the diagnosis and treatment schedule of BPH. You are seeing from the initial evaluation and to the treatment point of BPH. Nowadays we are mainly using the minimal invasive therapies, and I will mention about the tips and tricks for the endoscopic treatment of BPH. Surgery is mainly recommended for patients with the severe symptoms, refractory retention is and the worsening in the quality of life of patient. Concomitant administration of an alpha blocker is also an option prior to surgery. It may increase the results, positive results of the surgery. As I mentioned, surgery is recommended for the patients who have severe symptoms, and also renal insufficiency is one of the main points, clearly due to BPH. And in those patients with recurrent urinary tract infections, recurrent gross hematuria, bladder stones, clearly due to BPH, and refractory to other medical therapies are the indications of surgery. Well, I would like to talk about the minimal invasive therapies of BPH. I will start with TURP and continue with TUIP and laser treatments, endoscopic treatments of benign prostatic hyperplasia. I will start with transurethral resection of prostate. TURP is one of the most commonly performed operation of bladder outflow obstruction. It involves the surgical removal of prostate's inner portion, and it results with increasing level of urinating. And also currently monopolar TURP remains the gold standard surgery, and we are mainly using in our daily practice this technique. You are seeing the equipments for TURP surgery. The lens and the endoscope are the main equipments, and also the other resection electrodes that we are using for resecting the tissue of prostate, and evacuator when we are collecting the parts of the prostate that we have resected, and also electrode-free and sterile irrigation fluids, lubricants for the devices, and optional suprapubic catheter, but we are using a continuous system nowadays, recently. And these are two positions. You are seeing the left side right position, lithotomy position. 45 degrees is okay for the surgery, but the exaggerated lithotomy position, 90 degrees, is the wrong position for this surgery. And sphincteric mechanism, the main three components of sphincteric mechanism are bladder neck, intramural external sphincter. External sphincter is the main point of this sphincteric mechanism, and also levator ani muscle. During the surgery, there are some tricks for cutting a chip from the prostatic tissue. We are using resectoscopes for resecting these prostatic tissues during the surgery. And first one, lifting the front side of the resectoscope to allow the loop to sink in the prostate, and we are keeping it to the level as we cut the chip, and we are depressing the sheet to cut off the chip, and for collecting these chips. The shape of the chip is like a canoe. It is as wide and deep as the loop, and its length is determined by the travel of the loop. And also one other important point is cutting the chip off before the loop enters the sheet, and it prevents the damage. And one of the most important points of this surgery is the bleeding control. Smaller vessels may be controlled by coagulating its mouth, and larger vessels is controlled by applying the loop. But sometimes you are facing troubles for this bleeding control, and if localization of the bleeding site is difficult to reach, it's clearly the important point to face trouble for having enough bleeding control in this surgery. And the important points for the coagulation sites, you are seeing the 5 o'clock site and 7 o'clock site for the Badenoch's arteries. It's one of the main points of the surgery to have a better coagulation during performing this surgery, and also 10 o'clock is one of the other artery points. Main steps of TURP, I would like to mention about two techniques, Mauer-Meyer and Nesbitt technique during the surgery. I am mainly using Mauer-Meyer technique. And we are firstly giving the lithotomy position as I have mentioned in my previous slides. Blind trocar or visual insertion of the resectoscope. Resectoscope is the main point of the surgery, main equipment. Retrocystoscopy with identification of veromontanum before surgery, and prostatic urethra, we are examining endoscopically examining the prostatic urethra, bladder neck, and urethral orifices before performing this surgery. And orientation is one of the most important points of the surgery. The external sphincter is easily identifiable and at this level of the membranous urethra, and it is very important not to damage this external sphincter during the surgery, and also it is necessary to be aware of the position of veromontanum. This is one of the important sites that during the surgery. We can start with the Mauer-Meyer standard technique. It's an ancient technique, resection of lobes. We are starting with the middle lobe tissues lateral to veromontanum, and we are jumping to left lobe, right lobe, and apical tissues at the end of the surgery. In this technique, we are resecting the apical tissues at last. And you are seeing the endoscopic view of this technique and diagrammatic technique on the right side. Resection begins at the proximal portion of the middle lobe at 6 o'clock site. The resectoscope is placed just proximal to the veromontanum, and the resection carried out always controlling the end point for each cut. We are continuing resection, the resection of the middle lobe from 7 and 5 o'clock positions, sites. And we are continuing to veromontanum. And then after that we can jump into the left lateral lobe. And then after that, right lobe of the prostate, the proximal parts to the veromontanum. And this is the shape at the end of the surgery, shape of the surface, I mean fossa, and the resection of proximal part of both lateral lobes in lung cuts. Resection of apical tissues at the end of surgery is one of the main points that we must pay attention, because it is, as I mentioned, it's very important not to damage the sphincter for unwanted complications after surgery. This is one of the other techniques that we can use for transurethral resection of prostate, Nesbitt technique. We are starting, the main point is we are starting with proximal to distal parts of the prostate. And in this technique, we are also resecting apical tissues at last. We are starting with the basal parts, and at 12 o'clock, seeing circular fibers. And we are starting with, we are continuing with 12 o'clock to 9 o'clock. And after that, 12 o'clock to 3 o'clock for the prostate lobes, you are seeing in the diagram. And we are continuing to 9 to 6 and 3 to 6. And we are at last resecting the apical lobes of prostate. This is the last stage of this surgery. And after that, we are placing a balloon for urethral catheter and inflated to 20 to 30 milliliters. At the end of this surgery, TURP is one of the most commonly used technique for resecting the prostatic tissues. This is one of the other techniques, transurethral incision of prostate, and we are using this technique for smaller prostates. TUIP is an endoscopic surgical procedure. As I mentioned, to the smaller prostates, 30 milliliters or less with no median lobe. and we are using a Collins knife, an incision made to 5 to 7 o'clock positions of the prostate. It starts just distal to ureteric orifice and ends just proximal to verumontanum. This is the diagram of the incision of prostatic areas. This is one of the other diagrams. We are starting with 5 to 7 o'clock incisions of the prostate for smaller prostates in order to access areas for urine flow. And the other options are laser therapies. We are using 4 types of lasers in this type of surgery. And we are mainly in clinical practice, we are using the holmium laser, HOLEP technique, for resecting the prostatic tissues. And in the past we were also using green light laser, but it's not common in most of the clinics now. The energy can be used to achieve coagulation and vaporization. It depends on the preferences of surgeons. This is a diagram of green light laser. You are seeing the energy. We are giving energy from this side to the prostatic tissues in order to have enough access for the urine flow. This is one of the other diagrams. Green light laser operation. We are giving this energy to prostate, and we are resecting, vaporizing the prostatic tissues. It's also an effective surgery type. This is the HOLEP, holmium laser method. We are using this method, and it is very different from the traditional transurethral resection. During the traditional resection, we are using from the surface to the inner parts, but in this HOLEP operation, we are starting with the circular resection of the prostate, and then after that, marsupialization is used for getting the prostatic tissues. This is also another diagram showing the technique of HOLEP. And this is the endoscopic view. We are starting with laser energy in order to resect the prostatic tissues, and after that, at the end of the operation, we are using marsupialization to get these tissues out. Thank you very much.
Thank you, Selçuk. Is there any question or comments? Thank you.
I invite Dr. Çakçı for the presentation.
So, good afternoon, everyone. I will not use microphone. I walk with microphone. Oh, can I use that? Okay. Thanks. I'm a practicing attending urologist, which is a little different from the whole group. I am not into academic medicine, but in practicing side of the urology. And today I have 2 presentations. Both of them will be about practicing parts of the urology. Now, in the first part, I'm going to talk about practical skills of ureteral catheterization, suprapubic cystostomy, and retrograde ureterography. This is a bit wide because the ureteral catheterization is part of common medicine. that you have to know if you hold an MD degree, while a retrograde urethroplasty is, from my point of view, a hard job to do, beautiful in every situation. Okay. Now, transrectal catheterization is an absolutely life-saving procedure, especially our medical student friends will face with some patients that came out of their grave with just inserting a catheter. In infravesical obstructions, you will see some patients with edema and high creatinine values, and that patients will get better second by second after insertion of an urethral catheter. I think it's one of the greatest inventions of the humankind, and it has been used from ancient times. We know that this from ancient Egyptian texts, and one of the mainstays of the contemporary practice. I'm sorry. It worked. Okay. If you cannot catheterize the patient, then you cannot follow up the patient. Okay. Now, I want to say that all artwork in my presentations are completely original and drawn by my wife for you for this presentation. And if you take your attention to the size of the external genitalia, I hope my wife inspired by me, at least I hope that. The reverse is so bad for me. Now we see the way of the urethra. There's an external meatus and penile urethra, membranous urethra, and prostatic fossa inside the bladder. Now, if we take a look to the journey, with a ureteroscopy performed by me, we see a normal urethra, which is a tube. Tube. How gentle, how beautiful, how good. It's a tube. And now we see prostatic fossa. This is bladder neck, and inside the bladder. And the humankind used several different things, from wood to metal to stone to plastic to silicone to catheterize another people. We see the first manufactured, to our knowledge, catheter, which is used by a famous doctor, Ambroise Paré, and the contemporary sterile catheterization set, which we buy and use today. So, as I said, the urethra is a tube. It's gentle, and a simple and gentle insertion of the catheter inside the urethra should work. If it do not work, then there's a problem. And I always recommend global use of lubricants in catheterization, and use 1, 2, 3 lubricants to make your job easier. Using a sterile technique is fundamental, but I'm sorry, most of the times I do not use that. And the real art is always learned at the bedside. But in the future, maybe we will have some learning facilities for you. So what are the pitfalls? If you have a pitfall, first you can call an urologist. There's always someone on call and take care of you. So in stricture of penile urethra, so you insert the catheter inside the urethra, but you cannot forward it. There's a structure in penile urethra. This usually can be managed by using a bougie, which is a metal catheter, or making gradual dilation using smaller catheters to larger ones. But posterior urethral structures are prone to further damage and creating an iatrogenic false road in the urethra, which makes the situation, and upcoming surgery is complicated. Bladder neck structures can pass by hydrophilic catheters, and a big median lobe in prostatic fossa is a real problem. It can act as a pocket. It can take the catheter inside, and the blunt insertion tries will end with a vicious cycle. More blood, more edema, and unsuccessful tries. So, if we cannot perform a ureteral catheterization, what can we do? Another way to bladder. We can take another way. Suprapubic cystostomy. This is a step cystostomy. In my opinion, in my current opinion, as a practicing urologist, I think suprapubic cystostomy is also a common medical procedure. And I hope with this three-dimension facilities, in the future, all MD degrees will be able to perform this procedure. Not an alternative. It's not an alternative. If you can place an urethral catheter, then place it. But it's a necessity. So, also my wife's illustrations, an unavoidable placement of the catheter in a female patient and a male patient. The tricky point of the placement is the enlarged bladder, which takes the peritoneum upward. And an enlarged bladder gives you a beautiful window between anterior abdomen wall, as you see from here. But we have nightmares. These are not pitfalls, these are nightmares. Because if you have to see if you see these nightmares, then you have to come to hospital, and all the night will be spent on the patient side. True and true intestinal damage. As you see from this illustration, there is a difference. We see the peritoneum at here, at the bladder dome, but in this illustration, we see the peritoneal lining just behind the pubic symphysis pubis. Thank you very much. So, anatomy is important. Symphysis pubis. And this nightmare is not very uncommon. I first saw this complication in an old book named Master of Surgery, Volume Urology. After a successful placement of suprapubic cystostomy, they described a fistula, Guyta fistula, from the insertion stop point. So this is a real complication, and this has to be taken seriously. A massive ascites with prerenal kidney failure. I saw this while I was on call. My resident friends called me, said that we inserted a successful stop cystostomy to a patient who had globe vesicle, but the patient now still has globe vesicle and no urine is coming out. I asked that while you first insert the cystostomy, did the urine came? They said yes, a very, very large urine came. So they inserted the cystostomy inside the peritoneal area and drained massive acids, and then the catheter blocked. The patient in reality has acids and prerenal failure. And hematoglobe. I also have a bad experience with this. A patient who had undergone angiography, femoral angiography, was consulted to us with no urine output. And in ultrasonography, there is an image of hematoglobe, but in reality, it was an femoral aneurysm came into the midline. So we made a cystoscopy and see the real situation, and then cardiovascular surgery, take the patient. But while I was a resident, I one time catheterized a iliac vein. That's not a problem. Now, if we stand on the shoulders of giants, we make less errors because maybe hundreds or millions of people died until the humankind invented a clamp or sterile suture or a catheter. Now, use a sterile technique, really use a sterile technique, because in this time you are entering the abdomen. Use the ultrasound to see intestine behind the abdominal wall. Always make a puncture before insertion the catheter. Do not cut the catheter, because the contemporary sets are broken to two different parts while taking out, and all sides are cutting. So I also saw one patient whose catheter was cut during removal and fall into the bladder. Then the patient had undergone an exploratory laparotomy. And see the result, because the insertion of the catheter is never end. After insertion of the catheter, see the patient, safely make a suture, and take your coffee, watch the patient for some time, and if you are single, go talk with a nurse or a handsome doctor or someone like that. So retrography, this is a great tool of us, the urologists. This retrograde urography has no place in common medicine, but it's very important for urologists. It's a proficient diagnostic technique. Virtually, an urologist who has a retrograde urography laboratory under his or her hands can self-send his practice without any need of imaging or any other consultant service. Unfortunately, it's not performed commonly. I think retrograde urography is like old performed angiography of neurosurgeons, because before neurosurgeons were performing successful cerebral angiography and diagnosing their own patients, stroke patients or hemorrhage patients, also like urologists. But today we are very keen on radiology. The steps and the life lessons. As a practicing urologist, most of the times I keen on my experience from my mentors, from my observers, and the time I practice it in the rural area. So stay sterile, at least partially, because you're entering into a sterile system, is ureter and kidney. And perform sterile, totally. At least you have to wear sterile gloves, but all the myodesk should be sterile. Check the myodesk and fluoroscopy before the induction of anesthesia, which is, I think, the most important part of the procedure. Check the location of C-arm and use a hydrophilic glide wire. After the induction, after the patient is taken under anesthesia, you lose your eyes. Your eyes are the telescope and the C-arm. And you lose your hands. Your hands are the instruments. So check them every time, before every case. And you see one of our colleagues who has a very experienced retroscopist. He had a bad experience because a guide wire, a hydrophilic guide wire, which should have no tension, made a urethral perforation and went into the retroperitoneum. Therefore, I also recommend that take one fluoroscopy after insertion of the catheter. This will save you from bad experiences, complications, and cuts. So what are we looking for in retrograde urography? This is a normal QUB X-ray. As we see from here, this is a normal ureter, and we see a pathognomonic UP obstruction in here. We see that a filling defect, which is very important, and another filling defect in here. So in retrography, we are looking for filling defects, obstruction signs, and the anatomy of the ureter and collective system. My son, he is 10 months old. Thank you very much.
Thank you for excellent presentation, Özer. Any comment or question? Ayşe?
Thank you, sir, for your great presentation. First, I want to ask something. What is the most frequent complication you meet when you are doing a retrograde ureterography in a standard optimum patient?
Yes. First, we always look for complication-free procedure. But unfortunately, this is medicine. Some people die, some people live. And sometimes things go really bad. The most common complication I met was perforation of the not ureter, but UV junction. Unfortunately and surprisingly, most of the urologists, maybe I do that, after an experience period, getting into an overconfident state. So this overconfident state is very dangerous in a surgeon's practice. And I saw some friends who are making a blind insertion of the catheter before seeing the whole orifice, seeing a point and insertion the ureter without using a guide wire. This is very dangerous, and I saw some damage and perforation of the UV junction, which is very dangerous.
Others?
After unsuccessful ureteral catheterizations, would you like to perform a flexible cystoscopy and put a guide wire and insert the ureteral catheter over the guide wire rather than putting a retropic cystostomy? You know, most of the unsuccessful ureteral catheterizations are due to elevated bladder neck. What do you think?
Okay, first of all, I want to say that I have no significant experience in flexible cystoscopy during my residency period and while I was working as a consultant. Therefore, performing an acute flexible cystoscopy is out of my own capabilities. So I always perform a stop cystostomy, but from evidence-based medicine and information, it's feasible, and some patients get better very fast after one successful catheterization and taking out the inside the urine. So I think it's a good way, but unfortunately it's out of my capabilities.
No.
Thank you.
Thank you. We close this session. Another session. Please, Professor Mahir Özmen.
you have a microphone? So, dear professors, ladies and gentlemen, thank you so much for this opportunity to speak here today. It's my big pleasure. And in this section, we should speak about the liver surgery and pancreatic surgery. I have to say that the liver surgery is my biggest interesting. Thank you. Little bit bigger interesting. So I will have a little bit longer the presentation about the liver surgery, but I have few slides about the pancreatic surgery. It's a little bit slower, but we will be in time. I don't afraid. So in this moment, so I would like to speak about some points from the liver surgery that are important for us as surgeons. So first is liver regeneration. You probably know the ancient myth about the Prometheus, who was or that was chained in the Caucasian mountains by ancient gods, like a punishment. And the eagle returned every day to eat his liver, and this liver renewal every day. So still I'm not able to understand how they could know it, but in this time we know that it's possible. This renewal is possible because of hepatocyte renewal. It's the physiological renewal. Also because of the progenitor cells. We know these oval cells that are in the Hering channels, like second steps that's used during the liver regeneration. And third are the extrahepatic progenitor cells. It's usually stem cells from the bone marrow that are used in the situation of large liver damage and when the capability of the liver is not able to reconstruct and renew the liver tissue. So here we can see the hepatocyte cell cycle. Normally, hepatocytes in the G0, it's quite phase of the cell cycle, and after some stimulus, some injury, for example, so there are released the growth factor and interleukins. Typically tumor necrosis factor alpha or interleukin 6 that create that the hepatocyte switch from G0 to G1 cell cycle phase. This process is called as priming of hepatocytes. And after this, the hepatocytes undergo this cell cycle that's led by hepatocyte growth factor and the family of epidermal growth factor, like as transforming growth factor alpha, for example. And finally, these hepatocytes divided. In case when the renewal is finished, so transforming growth factor beta 1 is the main inhibitor of mitosis, and he switched the hepatocytes back to the G0 cell cycle phase. So second step are oval cells. There are progenitor cells, so we can find it in the channel of Hering's. It's the first channel of the biliary tree, and these progenitor cells are able to renew and differentiate in the hepatocytes and also in the cholangiocytes. So it's another step that's used in the liver regeneration. And third possibility are stem cells. They have two basic characters. They are able to self-renewal and differentiation in the other cell cycle or other cell types. And you can see that when they are released into the blood or bloodstream, so they can differentiate and proliferate in the mature cell. And typically for the liver, so there is still discussed the way how they could support the liver regeneration. First is that they could transdifferentiate under the effect of the local growth factor and cytokines. And they transdifferentiate into the progenitor cells and then to the mature hepatocytes and cholangiocytes. Other possibility is that these stem cells could fuse with the damaged hepatocytes and renewal the liver by this way. And third possibility is sometimes called as bystander effect of the stem cells, and in this situation, the stem cells release the growth factor cytokines, and they prepare some microenvironment for the regeneration of the hepatocytes. So other aspects are liver function. You probably know it. For us as a surgeon, is important the synthetic function of clotting factors. Also the effect of detoxification and excretory function that we usually assess in the liver function tests, like our ICG, indocyanine green test. Is how I said, it's test of excretory liver function when we assess the clearance of ICG through the liver. We administer this solution intravenously, and we have special photometric sensor. It's look like sensor for saturation measurement. So it's assess the plasma disappearance rate. It should be between 18 to 28% of ICG per minute, and also retention rate after 15 minutes. And in this retention rate test, so it's also depended the type of the liver resection that we could performed. There are also other type of liver function tests, but like our lidocaine test or some radionuclide method. But in fact, we don't use it, and I haven't experience with this type of this test. So something about liver anatomy. We had the presentation this morning about the liver segments. So I maybe say only that we can see the 4 liver sectors, and they are divided also for the segments that are called after the man who's called Koino. Yeah. So something about the terminology of surgical procedure. So it's necessary to say that every country or every continent have a little bit different way how to call it. In our country, we divided this liver procedure like anatomical resection and non-anatomical resection. Anatomical resection respect liver segments, and you can perform the segmentectomy of 1 or more segments. And also in very nice type of this anatomical resection are right or left hemihepatectomy or extended right or left hepatectomy. When we are speaking about large liver resection, so we mean that we resect more than 3 liver segments. Second one are non-anatomical liver resection. They don't respect the liver segments, and usually there are some smaller resection. It's usually only metastasectomy or some wedge excision. So here we can see some picture with the liver segment that are resected. So here we can see the right hepatectomy. So we take the segment 5, 6, 7, and 8. There are segments that are they have a blood supply from the right branch of portal vein. On the other hand, here you could see the left hepatectomy. We take the segment 2, 3, and 4. It's also dependent on the branches of the portal vein, and these segments are supplied by left branch of portal vein. And here in this photo, you can see special type of liver resection. When we take the segments 4, 5, and 8, and it's called like a central liver resection. I spoke about the extended liver resection. So it's mean, for example, here we perform the right hepatectomy, but we add also some another liver segment. The most common is segment 4A or B, and in this situation we call it as extended right hepatectomy. And in this situation, it's extended left hepatectomy when we perform the left hepatectomy, and we add some 5 or 8 liver segment. Here you can see the picture from our operating theater. Here is the performed left hepatectomy. Here you can see the structure of hepatoduodenal ligament, and here this is hemostatic material that we use for the stop small bleeding. Okay? In case when there is some vessel, for example, some branch of the vein, or hepatic vein or portal vein, so of course it's necessary to use some ligature and treat it by this way. This is only for the small bleeding. And here you can see the resection margin after extended right hepatectomy, and here is segment 2 and 3. So, other liver resection that we can perform are, in some countries, it's called as sectorectomy. When you take the sector, for example, right anterior sector, right posterior sector, left medial and left lateral sector. In our country, we prefer when we call it on the dependence on the segment that we resected. So we said, for example, that we performed the resection of segment 5 and 8, but how I said, it's dependent on the workplace. And here is the segmentectomy, for example, segment 6, and bisegmentectomy of segment 5 and 6. And here are examples for non-anatomical liver resection. You can see the metastasectomy from the right liver lobe, and here are the metastasectomies from both liver lobes. So what are the limitations of the surgery? In this time, it's the future liver remnant volume. It's the volume that then we leave at the patient after the surgery. You can see here this total liver volume, and this is the remnant volume that we leave at the patient, and here are the tumor that we resected. So when we take a healthy patient, healthy parenchyma, so it's enough when we leave their future liver remnant volume around 25% or more. And the patient that are after the chemotherapy, so we have to respect the future liver remnant volume between 30 to 35%. And the patient that are after the prolonged chemotherapy, so it's necessary to increase this future liver remnant volume for 40%. And in case of some diffuse liver disease like our cirrhosis, steatohepatitis, so it's necessary to calculate with the volume 40 to 50%. Here are two special situations that we can see at the patient after, for example, prolonged chemotherapy. That's yellow liver. It's yellow liver syndrome. It's also sometimes called as chemotherapy-associated steatohepatitis, and it's induced by irinotecan that is used in the chemotherapeutical regime, and all sinusoidal obstruction syndrome that sometimes called as blue liver syndrome, and it's dependent on the treatment of oxaliplatin. So how we assess the future liver remnant volume? So we use, or our radiologists use the CT volumetry with the manual calculation of the volume. It's really, it's not time saving. It's minimally half an hour for the calculation of the volume at the one patient. So with our colleague from the West Bohemia University, we try to develop some system that will be able to calculate this liver volume, but also we would like to use it for example, for the teaching of the students, but also for the planning of the liver resection on the dependence on the vascular tree in the liver. But about the LISA, you will see some special presentation tomorrow, and you will have a possibility to try to work with this LISA system. So at the patient with the cirrhosis, there we have to respect some other criteria. You know the criteria of Child-Pugh that we assess the encephalopathy, ascites, bilirubin, albumin, and prothrombin time. And then you can see this tree how to decide for the liver resection. So we can resect only the patients that are in class A of Child-Pugh score and are without portal hypertension. In this situation, we have to calculate the future liver remnant volume, and if it's bigger than 50%, so we can perform the resection. In case that is not so big, so we can assess the ICG test, a retention test, and in the dependence of this test, we can have other possibility how to augment the future liver remnant volume, for example, for the portal vein embolization. It's other procedure how to augment future liver remnant volume, and we will speak about it tomorrow also. So Makuchi is a professor for Japanese, and he has other type of how to decide for the liver resection. You have to assess AST test, total bilirubin level, and again ICG retention test. And in the dependence of this test, the patient could be indicated for the liver resection. So what type of liver tumors? So we can see the benign and malignant tumors. Benign tumors are usually liver cyst, hemangiomas, focal nodular hyperplasia, or hepatocellular adenoma. From the malignant tumors, there are primary tumors, hepatocellular carcinoma, cholangiocellular carcinoma, and in our country, the most common are the liver metastases of the colorectal carcinoma. So benign tumors are usually asymptomatic. So in this situation, we only check this patient in the regular time. Usually it's between 6 months and 1 year. And in case of some clinical symptoms, typically pain or dyspepsia, so we indicate it for the therapy. In case of hepatal adenoma, we have to be very careful because there is a risk of malignant growth, and there is also a risk of bleeding when this tumor is bigger than 5 centimeters. So this patient are usually indicated for the resection. Other possibility how to treat the benign tumors, typically hemangiomas, is radiointerventional therapy. And for example, laparoscopic surgery for the patient with the liver cyst, when we perform the fenestration and take the sample of the wall of the cyst for the histological examination. And how I said, open surgery we usually indicate at the hepatal adenoma for the resection. So here we have to picture from the CT of the hemangioma. You can see it's really a huge hemangioma, and we treated it with cooperation with our interventional radiologists, and they performed the intra-arterial embolization with the special tissue glue, and it's a relatively elegant therapeutic method, and after 5 days this patient could leave our hospital. And here is the procedure, here is the catheter, he assessed the liver hemangioma. Here you can see the tissue glue, how to occlude the vessels, and here is the control CT with the tissue glue, and here you can see that the hemangioma reduced the volume. So how I said before, the primary liver carcinoma are limited for the surgical therapy because of the cirrhosis. So this criteria we have discussed before. I only said again, Child-Pugh classification, function test, and future liver remnant volume that's bigger than 40 to 50%. So, and also some examples from our department. This is patient with the hepatocellular carcinoma. You can see it here. We calculate the total liver volume and future liver remnant volume. It was 72% for the future liver remnant volume. Here you can see the model from our ELISA system. And you could see here is the line that was planned for the right hepatectomy, but for this patient it was really big procedure. We plan here to perform only bisegmentectomy. But finally, When we opened the abdominal cavity, so this patient has had unfavorable preoperative finding. There were many adhesion and low quality of liver parenchyma. This parenchyma was very glacial. There was very big risk of postoperative bleeding, so we had to finish this procedure like exploratory laparotomy, and we provided only palliative treatment for this patient, like transarterial chemoembolization. We use special microspheres, and interventional radiologists place this microsphere near the tumor, and this microsphere are related with the chemotherapy, and this chemotherapy is releasing in the bloodstream for this tumor. Second patient with hepatocellular carcinoma, here you could see the tumor in the segment 2 and 3. So again, we have the picture from our LISA system, and here we plan to perform the left hepatectomy, because how you could see here, the future liver remnant volume was adequate for this resection, so there was performed the left hepatectomy. After the procedure, we could see the small complication. There was collection at the resection margin, but it was without surgical therapy. There was enough to treat it with the antibiotics, and the patient left our hospital after 11 days. So other type of the carcinoma is carcinoma of gallbladder. This patient has usually poor prognosis, and the operability is dependent on the infiltration of the biliary tree, lymphatic nodes infiltration, and also on the dependence of tumor spreading through the liver parenchyma. Here you could see the gallbladder and the infiltration of the gallbladder bed in the liver parenchyma. We also assess it in our LISA system. Here it's necessary to say that the resection of the gallbladder bed is not so big, so here we don't usually use the assessment of future liver remnant volume. And at this patient is usually indicated the cholecystectomy with the resection of gallbladder, gallbladder bed, and lymphadenectomy of hepatoduodenal ligament. So here you can see the lymphadenectomy. Here is the sample of gallbladder and the gallbladder bed with the liver tissue, and here you can see the resection margin after the procedure. And here is the patient with the secondary liver tumor. He has metastasis of colorectal cancer. It's the most common disease in our country, and there was metastasis in segment 4A and S8. This patient was planned for non-anatomical resection of segment 4A and 8. And this patient was without complication. Here is PET-CT, because the metastasis here, it's not so good visible on the CT, but the PET-CT is clear finding here. And we also use again our LISA system. So you can watch it here also in this three-dimensional model. So, and last slide is about the liver complication. So the most common is the collection at the resection margin. It's usually caused by postoperative bleeding or biliary leakage. So usually in case of the collection, so we usually indicate the drainage under the CT or ultrasound control. In case of biliary leakage, when we can identify in the drainage after the operation, so we can indicate the ERCP with the stent placement. Most severe complication is a massive postoperative bleeding or biliary leakage, and we usually have to perform open surgery revision. And pneumonia and fluidothorax as a reactive process after the surgery in abdominal cavity, antibiotic treatment, sometimes thoracic cavity punction. And last one, and it's the biggest nightmare in the liver surgery, is postoperative liver failure. It's it's not possible to treat it, and it's fatal for the patient. So we have to prevent it with the CT volumetry, assessment of future liver remnant volume, function test, and it's also dependent on the right decision about the indication, the patient for the surgery. So here is a picture of the biliary leakage here, ERCP, and type of plastic or metallic stent that's used for the patient with the carcinoma. Here is the collection near the resection margin after the right hepatectomy, drainage under the CT control, drain on the control CT, and again the collection is reduced here. So, conclusion and take-home message. So, every time it's necessary, right decision about the liver resection that's dependent on the adequate future liver remnant volume and liver function test. So, we use the CT volumetry for it, and it's necessary to know that the diffuse liver disease changed the condition for the liver resection. Thank you so much for your attention. And I don't know if no.
Although I said questions at the end of two speech, but it's two separate subjects. It's better for us to discuss this one first, and then we can move on the second presentation. Thank you for the presentation. I'm a professor of surgery, and I do a lot of liver surgery. I do not understand what is the main difference between your LISA and the CT reconstruction and CT volumetry that we are currently using. Especially if you have a Siemens CT scan, then you can do all the reconstruction easily, and you can measure the volume before the operation, and also you can get a connection of your operating table and the CT scan, and you can get a picture of the section margin during the procedure. You can follow the CT margins and the margins during surgery. So I don't know, I mean, which kind of advantages that you are offering by using your LISA?
Yes. In this time, it's still in development, and it was developed for our experimental procedure. But we would like make it better for the planning of the liver resection, with the planning with the planning of the resection line, and also in the cooperation with our doctors from Department of Anatomy, when they are doing the corrosive preparates, and we would like to study the microstructures of the liver. Yeah, so it's our vision. I know in this moment that we are on the first steps of our development, but we have this goal, and we would like go by this way.
My co-chair is assistant professor in Department of Surgery at State University, and he's working with me in the Lviv Hospital also. Emir, you have a question for this?
It's a new technique, I guess, about the rendering volume rendering for transplantation.
No, we are not perform transplantation. We are our department. It's not transplant center for the liver organ. We transplant only the kidneys, but we want to plan it for the patient that have low future liver remnant volume, and we use it for the calculation and then indicate it for example for other procedure, how to augment the future liver remnant volume, like our portal vein ligation, embolization, ALPS. So I will speak about it in tomorrow presentation.
Mr. President, sorry, I don't understand. I have to ask the question here. What's the main question for you to start this work? What's the main difference is going to find by the investigator that it's going to affect the future applications of liver surgeons, that it's going to make huge difference than it's happening now?
Yeah.
Because we already use this technique.
Yeah, we use classical CT volumetry from the Siemens, for example, in our clinical practice. We use this LISA in our experimental studies in this moment, but in the future we would like to balance the differences between the, I don't know, CT Siemens volumetry and LISA. I know we are on the start. Yeah, we started.
It's much cheaper than the Siemens system.
So we would like have it like open platform. This one. Yeah.
Right. Okay, you don't actually need to have a huge CT scan to use your program. It's going to be open. It's going to be publicly used. It's going to be available for everyone to
so it's question maybe for our Master of Science, but yeah, it's open.
CT scan anyway.
It's open. Yeah.
CT scan, you cannot do that. So most CT scan machines comes with the reconstruction program together. So you can reconstruct the CT scan of the liver on that machine and on that program.
So yeah.
LISA is going to make maybe anything different.
Sorry. Yeah.
Emre is going to ask the question.
Maybe I'm not. I want just.
Sorry.
I mean, because early in the morning we talked about, Lada also talked about the corrosion tests for surgery. Because we visited their biomedical center. They had a really great center. They are doing experimental surgery. I mean that the LISA is a program developed by the center for using the experimental surgery. Am I right?
Yes.
Okay.
That's absolutely. Okay, the second part of the speech is going to be on pancreatic surgery. So Jacques is going to talk about pancreatic surgery.
Yes, thank you. So, thank you so much, and a few slides about the pancreatic surgery. So, when we are speaking about pancreatic tumor, so from more than 80%, we are speaking about the pancreatic adenocarcinoma. It's necessary to say, it's necessary to say that the, I don't know which microphone is working. Oh, okay. Sorry. So it's necessary to say that the surgical therapy with the R0 resection could be only one curative procedure. So problem with the pancreatic tumors is that it's a very, very aggressive type of tumor with quick progression. So that's why the patient, when I visiting us, so it's usually late for some treatment because there is late diagnosis. They have usually clinical symptoms like back pain or dyspepsia and loss of weight, and in this situation they have lymph node metastasis or distant liver metastasis, for example, and it's the stadium that's not possible to operate. Here is one clinical symptom. It's painless jaundice. It's a little bit discutable between the symptoms. For example, tumors that are very near for the Vater's papilla. So there could be a relatively early sign of some problem, and in this situation, it's possible to operate this patient early. So the diagnosis of pancreatic cancer is usually by ultrasound. That's like first examination that we used. There we have usually some suspicion for the tumor, so we indicate CT or MRI for assessment of the tumor localization, size, invasion to the vessels. Sometimes it's necessary to perform ERCP with papillosphincterotomy and stent placement, typically at the patient with the cholangoitis. It's question if it's necessary to use it at the patient with jaundice because when we are able to provide this patient early term for the operation, so it's not necessary. There is some delay between the diagnosis and the surgery, so it's usually necessary to perform ERCP and papillosphincterotomy. Other possibility is use of endoscopic ultrasound with fine needle aspirating biopsy and or PET-CT in case of when we have a suspicion for distant metastasis. So pancreatic cancer, most cases are located in the head of the pancreas, then is tail of the pancreas, and 10% is in the neck or body of the pancreas. For the resection are indicated the patient with tumor TNM classification with the tumor 1 to 3 and lymphatic nodes. In case of the T4 or situation when the patient has a distant metastasis, so this stadium is not possible to operate because of very poor prognosis of the patient. It's necessary have to write CT angiography because it's necessary to assess the invasion through the portal vein or invasion through the mesenteric vessels. It's necessary to say that this situation is not contraindication for the resection, but sometimes necessary to cooperate. The vascular surgeon is very hard to perform this procedure, and sometimes it's necessary use some prosthetic material for the reconstruction of the vessels. But how I said, it's very hard to perform it. For the surgery, we usually perform for the Whipple resection. It's the resection when we perform the cholecystectomy and bile duct removing. And then we resect the distal stomach and duodenectomy, and we finally perform the resection of head of the pancreas with the tumor. It's the classical type of the Whipple procedure. In this time, it's preferred the procedure where is pylorus preserving. For the tumors that are located in the tail of the pancreas, so it's possible to perform the distal pancreatectomy, dissect the pancreas in the pancreatic body, and then we proceed on the lateral side. Sometimes it's necessary to perform also the splenectomy with the resection of the distal pancreas. And last procedure could be total pancreatectomy, but there is high number of the complication, and this procedure is used very minimally in our country. So here is the schema of the Whipple procedure. How you could see, so first is performed the cholecystectomy, resection of the distal part of the choledoch duct, then cut the pylorus or duodenum near the pylorus, proximal part of the jejunum, and finally cut the head of the pancreas with the tumor, and it's the sample that we remove from the patient. How I said before, sometimes it's necessary to perform the small resection of the, for example, wall of portal vein, and it's necessary to reconstruct it. Yeah, so you can see here reconstruction, and then you have to reconstruct also the gastrointestinal tract. So you have to perform the pancreato-jejunoanastomosis. We usually use end-to side anastomosis, hepatico-jejunoanastomosis also end-to side, and gastro-jejunoanastomosis also end-to side procedure, and finally jejunoanastomosis side to side. So, and this is final reconstruction. So about the complication, pancreatic surgery has high morbidity. It could be around 50%. The smallest complication is the wound complication. Again, our nightmare is complication in the anastomosis, typically pancreato-jejunoanastomosis. Other complication is bleeding. It could be early, immediately after the operation, and late it could be in the situation when the pancreatic content indurate the wall of the anastomosis, for example, and it could start to bleed. And last one, what I note here is the pancreatic fistula. It's also very severe complication with the long time for the healing. So, and finally, we also try to segment or perform the reconstruction of the pancreas with the LISA. So you could see that that here's the tumor, but we have to work harder for this segmentation. But our goal was to use LISA especially for the liver, and this was only we only wanted to try it, how it will look when we perform it in the LISA. Thank you so much.
Thank you for your great presentation, sir. I want to ask that, in your opinion, will the three-dimensional simulation of the real organs will contribute to increase the overall survival for hepatopancreatic tumors in the future?
Yes, thank you for the question. So we plan it for we use for it planning of the operation. So for the patient is the best way how to treat them to perform the surgery with the clear margin resection. So it's our goal. We use this models, or for example calculating of the future liver remnant volume, or here in the pancreas for the assessment of the local situation, how the tumor, for example, is in the relation with the vessels, and if it's possible to perform the surgery. So I don't mean that it could increase the overall survival, but it could increase, for example, quality of life for the patient that are primarily inoperable, and we avoid the situation when we perform only explorative laparotomy and the patient has a big wound in her abdomen or him abdomen, and finally we only create some pain for them, and we couldn't help them. Yeah.
I'd like to add something to your question. If you can increase the resectability of the tumor, then you can increase the survival of the patient as well, especially for the colorectal tumors. Not for the HCCs, but probably it's going to help for the colorectal metastasis. If you can increase the resectability, then you can increase the survival. So this program and the program that we are currently using is definitely helping to increase the resectability of the tumor. Yes, please. Thank you for this. Please introduce yourself first and then ask the question.
I'm Dr. İlker Selçuk, a gynecological oncologist in Ankara. Thank you for the excellent presentation. That I want to ask about. We know that that region has a complex anatomy, celiac artery, and also supramesenteric artery and veins, and other things, hepatoduodenal ligament and arteries and veins, and also the other things. So, first of all, I want to ask that, did you perform this simulation before surgeries, and what's your patient size, patient cohort?
You mean this LISA system, or?
Yeah, in real life, did you perform it?
So how I said before, so in this moment it's only experimental program. Yeah. So we use the data from the patient, but we can use it in the clinical situation. Yeah. So it's our goal to use it in the future, but in this moment we have to use classical CT scans and so on.
And from now on, you haven't performed it for live patients, for live surgeries.
We performed, for example, at the liver, we performed the calculation of the future liver remnant volume. Yeah, so we calculated with the CT Siemens system, for example, but not yet with our program. But it's in the future, it's our goal.
It will also be used for gastric carcinoma, also for D2 resections, and also. It will also increase the resectability, and also maybe the primary point will be decreasing the complications, and the secondary end point will be increasing of the survival for that simulation. Maybe that's very good.
Before giving I'll add something to that. Gastric cancer is completely different. it's a hollow organ, and I do a lot of surgical oncology. I'm a surgical oncologist. Gastric cancer is my main interest. So you cannot use the volumetric assessment for the gastric cancer. You can localize the tumor. You can check the lymph node involvement for the tumor, but the volumetric assessment is especially important for the solid organs like liver, pancreas, kidney, maybe spleen, uterus. Probably you can actually assess use the assessment for that. But my question is the size of the patient. You ask for the size of the patient population, but the size of the patient. Current CT scan we cannot actually use in a patient who had the body mass index over 50. You cannot assess the volumetric index for liver in a patient with super obesity or morbid obesity. It's not always useful to do that. But with your program, probably, especially in that kind of patient, it's going to help to assess the liver volume properly. Because I mean, most of that patients cannot get into the CT scan because of their size and the volume, and because of the fat tissue and steatosis around the liver. It's going to stop us to get a precise assessment of the liver. Maybe your program can change that a little bit as well.
We hope for it, and how I said, we use this for classical CT scans for the assessment of future liver volume. So when it's fine finding there, so we indicate it for the resection. But many times it's happened that the local finding in the abdominal cavity, it's impossible to treat by the surgical procedure. So every time it's combination of these CT scans and with the local finding during the operation.
Yes. Thank you, Sean. Thank you very much for this nice presentation. In the morning, I present the project part of the urology section. Only, I would like to ask to give us information about the training. A little bit, I want to move from the patient care to the research and the teaching. And I know that on Saturday we will do mostly hands-on training session with 11 stations and 2 stations appointed for generals for surgery. Can you give some information about based on your presentation and our students, our residents, and also as I am really a little bit curious about how we can adapt this volume rendering, especially for kidney surgery or some. I totally agree with Professor Özmen about for solid organs, it can be disseminated for that. Can you give some information about the training-based module that we will do on Saturday?
Yes, so we have data from our patient. In our situation, there are patients with the liver tumors, but you will have a possibility to train to calculate this future liver volume by this system. Yeah. But in this time we have a patient with the for example the kidney tumor, but I mean that it's no problem in the future to prepare some program where it will be calculate the volume, for example, or segmentation of the kidney. It's maybe a question for our Master of Science if it's technically possible to perform it.